Good morning or afternoon. I have no disclosure. Validated risk models such as Gale, Claus, Myriad BRCA Pro, and Tyler Cusick models can estimate an individual's lifetime risk of developing breast cancer. When a woman's risk is found to be elevated, the American Cancer Society recommends supplemental MRI screening to improve early cancer detection. The National Comprehensive Cancer Network also recommends consultation with specialists to discuss possible further genetic testing and risk reduction strategies. Increasingly, risk assessment is being performed by commercially available software at screening mammography facilities. This has the potential to reach a wide audience as 70% of American women aged 50 to 74 years undergo screening mammography. However, post-implementation studies available so far have shown only a modest increase in referral to specialists and adherence to MRI screening. The purpose of this study is to investigate patients' level of interest in learning about estimated lifetime risks of developing breast cancer at time of screening mammogram, and to learn of preferred method of risk communication in a diverse population of women of different races, ethnicities, age, and socioeconomic status. A 21-question survey was created and aimed to inquire about patients' interest in learning about lifetime risk and preferred method of risk communication for two hypothetical scenarios where risk is average, scenario A, or where estimated risk is elevated, scenario B. Survey also asked about preferred level of detail for both scenarios. The survey was distributed to all women aged 18 or above, presenting for screening mammogram at 8 mammography sites in central Massachusetts associated with the UMass Memorial Medical System. From February to May 2019, participation was voluntary and anonymous. The survey was also translated into 5 most common non-English language encountered at UMass, namely Spanish, Portuguese, Vietnamese, Arabic, and Albanian. A total of 683 surveys were included during the study period from 8 out of 8 mammography sites. Notably, 11% of the participants identified as race or ethnicity other than non-Hispanic Caucasian. 28% reported lower than average median U.S. household income, and 16% reported high school education or less. All respondents who completed the question about insurance status reported having health insurance. Out of these participants, 87% of women expressed interest in learning about their estimated lifetime risk of breast cancer, whereas only 9% reported having had their risk assessed by a healthcare professional. In a sub-analysis, women with income between $40,001 and $65,000 were significantly more likely to be interested in risk assessment than those with income less than $20,000. In a hypothetical scenario where estimated lifetime risk of developing breast cancer is average, or scenario A, 57% of women selected mailed letter accompanying annual mammogram as one of the preferred method of communication, making this method the most frequently selected. 27% of women elected to receive mailed letter accompanying the annual mammogram results as their single preferred method of communication, whereas 20% exclusively preferred face-to-face communication. In the hypothetical scenario where estimated lifetime risk of developing breast cancer is elevated, or scenario B, women most frequently selected a face-to-face meeting with radiologists who interpreted their mammogram and mailed letter accompanying their annual mammogram results, both at 43%. However, 30% chose face-to-face communication as their single preferred mean of communication in this scenario. A pair comparison showed that more respondents exclusively prefer face-to-face communication of elevated risk estimate than for average estimate with p-value less than 0.0001. Age, race, ethnicity, income, and educational level were not significantly associated with the likelihood of selecting face-to-face communication in either scenario. Telephone communication was also more frequently selected as one of the preferred method of communication in scenario B compared to A, 40 versus 30%, with p-value less than 0.001. After controlling for race, ethnicity, income, educational level, and history of breast cancer, younger women aged less than or equal to 39 years were more likely to prefer phone communication of elevated risk than those aged 40 to 49. Online communication, defined as email or viewing results on online portal, was less frequently selected as one of the preferred method of communication in scenario B compared to A, 13 versus 18%, with p-value less than 0.001. After controlling for race, ethnicity, income, educational level, and history of breast cancer, women aged above 60 were less likely to prefer online communication of average estimated risk than those aged 40 to 49. After controlling for age, race, ethnicity, and educational level, women with annual income between $65,001 and $106,000 were more likely to prefer online communication of average estimated risk than those with annual income less than $20,000. The majority of respondents preferred to receive very detailed communication about their risk in both scenario A and B, 57 versus 80%, choosing high level of detail respectively. Among women who responded to the question for both scenarios, 30% of women requested more detail in the elevated risk compared to the average risk scenario with p less than 0.001. After controlling for race, ethnicity, income, educational level, and history of breast cancer, women aged above 60 were less likely than those aged 40 to 49 to prefer very detailed communication in both scenarios. And after controlling for age, income, educational level, and history of breast cancer, women identifying as African American were less likely than those identifying as non-Hispanic whites to prefer very detailed communication in scenario B. Despite a small number of women in this subgroup, African Americans were also the only group of women who preferred less detailed communication in scenario B compared to scenario A. Limitations of the study include small number of African Americans participant compared to the overall population in this region. There is 1% of African American in this study population versus 6% in the county containing 7 out of 8 mammography sites studied in this study. Although published data suggests that fewer African Americans than non-Hispanic whites receive screening mammogram in this region, 44 versus 55% respectively, this difference is likely not sufficient to explain the low African American participation rate, suggesting that there is a high level of survey refusal rate among African Americans. Another limitation is a small number of non-English speaking women, despite providing surveys in 5 most common non-English languages in the study population. All non-English speakers were combined into a single group to improve statistical power, which prevents analysis of differences in preference among different non-English speaking populations. The study also inherently excluded women who are illiterate, and lastly, due to the effort to preserve patients' anonymity and uneven recruiting efforts by personnel at different sites, a true response rate could not be obtained and selection bias may exist. In conclusion, although most women were interested in learning about their estimated lifetime risks of developing breast cancer, the proportion of women interested was lower in lower socioeconomic group. Telephone and online communication, despite today ubiquity, may be problematic for patients with advanced age or lower household income. And lastly, screening mammogram facilities implementing risk assessment should consider risk communication strategies that are most effective for their patient population. Thank you.